Super. Good afternoon, everyone. It's a pleasure to have you all here in the room, and I also want to welcome people who are joining us on our live stream. For the next hour, we will be having a conversation on where we are with COVID and where we might be heading. We have a panel here that represents government, a business, industry, and charitable organizations, as well as NGOs. If you are tweeting, which we welcome, about this event, please use the hashtag WEF22. Now, I want to maybe start with a little speed round for our panelists, just to get us going. And I'm going to ask the same question of each of you and give you, let's say, 60 seconds to answer. What worries you most in the next 6 months about where we are with the pandemic, and what would sort of best alleviate those concerns? And maybe we can start with Jeremy Farrar of Wellcome Trust.
60 seconds. Firstly, the politics and societies move on too quickly, and realize that it ain't over yet and start to think it's finished. Secondly, China really worries me. I think they can't avoid an epidemic. I don't think zero COVID is a possible. And of course a new variant that comes out. And then lastly, another event happens. Because we've had a number of events over the last 20 years, every 2 or 3 years. And monkeypox should just be a reminder. We're not in control of nature, and we could have another event.
Gabriela Boucher from
Oxfam.
Oxfam.
Yes, thank you. So I think what would worry me is something similar, that the rich world in particular moves on and feels, it's over for us, we're all vaccinated, it's no longer a problem, and we're forgetting about what's happening across the world, the global south, which is still having waves of the virus and the low rates of vaccination, 15% across Africa at the moment. So that the focus moves away, and that is not addressed. And the fact that we don't have, it's not a public good, it's not a readily available vaccine globally at the scale needed, means that in 6 months, the complacency that is perhaps felt now could be really deadly.
Super. Maybe Amitav Kant, who is the CEO of the National Institute for Transforming India out of Delhi.
What worries me is the impact of the pandemic on learning outcomes of children. 2 years of education of young children in school level has been wiped out. What worries me is the impact on women in a very big way. And I think the important thing is to get these children back to make up for their education. Important thing is to continue with technological breakthroughs, because this is not the end of COVID. You will have new varieties, and you'll have to keep finding technological answers.
Terrific. Now turn to Seth Barkley, who's the CEO of Gavi, the Vaccine Alliance.
So, of course, I have to agree that we have to worry about evolution of viruses, and it isn't over yet. And with that, we have to really worry about the complacency. And as others have said, you flip on your telly and you see everybody going on with life as normal in highly vaccinated places. There is enough vaccine now to vaccinate everybody in the world. So that's the difference. That wasn't true 6 or 8 months ago, but it isn't as much of a priority now for countries to do that. And I think that's something that we really have to pay attention to, because when we have a new variant or see another epidemic start, it can have the same devastating effects, particularly in high-risk groups who are not having very, very high coverage yet in all countries, including some wealthy ones.
Terrific. Stéphane Bancel, who's the CEO of Moderna.
Well, thank you. Being the fifth of this team panel, I won't have a lot of new stuff, but I will say still a lot of people not vaccinated in the south, but also in the north. We should not forget that in the US, despite having great technology for a long time, we have only half of people who get vaccinated got boosted with third dose, half. So I worry about next fall and winter as the antibody level goes down. like Jeremy, I worry a lot about China, because I think as the virus becomes more and more infectious, it's less and less controllable, with techniques that were wonderful in 2020 to prevent a lot of deaths. And then, as Seth said, we need to always be humble with biology, which I worry we might have down the road, and it might not be in the next 6 months, a more virulent variant. Because we should never forget the past, which is Delta came after Alpha, but was more virulent. And so while Omicron was good news, was less virulent than Delta, we are always a day away, or a week away, or a month away, or a quarter away from a new one that's pretty bad in terms of virulence.
Yes, Gabriel.
And I say something that worries me more deeply, because beyond the 6 months, is that we still have a model going forward that would not allow us to get ahead of the virus and to actually really prevent transmission and to hope to really cover large numbers of the population as fast as needed. So we really need to rethink the model if we want to be ahead for this pandemic and any future pandemic.
Super. Since I'm from Politico, we always like to survey the audience and see where views line up. I think that's a really great overview to get us going in this conversation. And maybe I think to begin with, I want to maybe dig into this, to the vaccine question. And I think here we're going to touch on complacency again at some depth. And maybe I can start with you, Stefan, where obviously Moderna was out of the blocks very early, got a lot of credit for developing the vaccine that a lot of us have taken. But I remember very early on, you made sure that the US government tried to sort of get permission from you to sell vaccines on to low-income countries. And you've been quite jealous with your intellectual property, as a company would, presumably. I noticed that more recently you agreed to extend a waiver in March to low-income countries, and you're also building a plant in Kenya. I wonder sort of what changed in your mind or in Moderna's mind.
So on the IP, we made actually the commitment not to enforce IP to any company back in the fall of 2020, before we even had the vaccine data available from the phase 3. What we updated in March is we said we will never enforce the vaccine against COVID-19 in low-income countries. The plant in Kenya is just part of us trying to build a resilient network of manufacturing, because, as you know, when the pandemic started, Moderna had no manufacturing capacity, never sold a product. In 2019, just to give you a sense, we had made 100,000 doses for the entire year. So imagine the face of my head of manufacturing, where living from Davos and having the good coaching of Jeremy and Seth and Richard Hatchett saying this is going to be a pandemic. I asked my head of manufacturing, how do we do 1 billion doses for 2021? And he paused and he's like, what? He's like, yeah, 1 billion doses. He's like, we only made 100,000 doses last year. I said, I know, stop wasting time. Tell me, what do you need so that we can make 1 billion doses next year? And the number 1 billion was already an incredible number for us, given where we came from. This is like a 10,000x increase, which ask anybody who makes stuff, like car makers or phone makers, if you need to make 10,000 times more in 12 months' time, they'll tell you, I don't know how to do that. And the other piece that, as I look with insight, I wish I had a crystal ball, which of course I didn't have, which is, if you had told me in March 2020, when we made all those big investments for manufacturing, that Merck vaccine was going to fail, and that Sanofi was going to be a late year, and Novavax was going to be a year, I might have tried to do even more. But at the time, 1 billion doses was significant, because just the entire capacity for all the flu manufacturers around the planet is 500 million doses a year. So already what we are trying to do was twice the entire market for 4 companies around flu. And so that's a piece that I can never go back in time, obviously. I wish I had known that so many other vaccines were going to fail, and we might have tried to do more. But we added capacity at the end of the year 2020. But because of the time it takes to build, the impact only was felt in the summer of 21.
Maybe a good segue to Seth, and I wonder, is it too little, too late? You've sort of had stories out of Africa that people are reluctant to take the vaccine. They've lost confidence in it. There was a interesting article in the New York Times about a plant that's been built in South Africa to produce, but they're having trouble finding buyers. And I wonder whether you can hope to make a dent in the next year or two if people are not even taking up the vaccines now that they become available. And Gabriel, too, please.
Yeah, so I mean, what happened, and we were part of this discussion starting in Davos now, 2.5 years ago, the plan was to try to go ahead and move as close as possible to having vaccines available in North and South. And we had the first vaccine in developing countries 39 days after the first injection in a high-income country. It's never been done before. And there were plans for those to scale up, but we ended up with nationalism and export bans. And at the end, we had to call for help, and we asked for dose donations during that period. We went to other suppliers during that period to try to get doses, and it has moved slower than it should have. Now, I think, the important thing to say is we don't have a transmission-blocking vaccine here. That's very important. So what this is about is trying to protect people against severe disease and death. And initially, our goals were to try to get about 20% of people vaccinated around the world. And there was a lot of controversy about that. Are we capping people to 20%? So it wasn't the ceiling, it was the base. And the idea was vaccinate your health workers, vaccinate your elderly, vaccinate people with other comorbidities, because that's how you protect the health system. That's how you do the best job. And we didn't end up having that. We ended up having leaders who said, my country, only my country, we're not going to share, we're not going to export. And that ended up having a dramatic effect. So I think that the solutions for this are many, but one of the most important things we have to do is diversified vaccine manufacturing. When Gavi started here in Davos in 2000, there were 4 manufacturers. 4 of the 5 were in wealthy countries. Today, there are 18 manufacturers. The majority of them are in developing countries. And, we need a lot more footprint. There's only one pre-qualified manufacturer right now in Africa. That is the Pasteur Institute of Dakar. So we do need to expand there. But the critical issue for those companies is the planning needs to be done to have a sustainable manufacturing system, like many manufacturers in India have done.
I want to come back to that with Mr. Khan, but let me just ask Gabrielle, because Oxfam has been pushing for waivers, not just for vaccines, but also therapeutics and other procedures. And I wonder, are you satisfied with the response of industry?
So I think, the story of the vaccine has been a story of contrast. So it's true there's been innovation, scientific development. It's been incredible, and collaboration with governments and companies like Moderna and many on this panel. And the speed at which the vaccine was produced is really commendable. What hasn't happened, and then Seth was saying, is that this hasn't reached the world. So there's been a hiding behind, there's the IP is quite a complex matter. There's also the model, which is around profit. And at the moment, what we really need is to have a technology transfer so that the World Health Organization, Dr. Tedros, has set up an mRNA hub in South Africa. And in fact, he's asked Moderna, Stéphane Bancel, he's here, he can tell us, would you share your technology with that World Health Organization mRNA hub in South Africa? Because we're losing time. They've spent a year working on the technology to be able to really amplify production across the world. So the idea is to have a series of very highly qualified vaccine manufacturers who in fact produce vaccines, other vaccines, and have the experience, but to be able to do it fast at scale so that in the event of other variants, there is the right response and not this situation that happened, as Seth was saying, that the rich world hoarded the vaccines, got 70% plus vaccination rates, and everybody else was at the back of the queue. So now we have vaccines, but they are for the current, which of course doesn't prevent transmission. So if vaccines are improved or we have new forms, we have again the same situation with the current model where there would be a need to wait till the first world, the rich world, gets vaccinated. And that's what I'm saying. We need to really change that model and have really unleash the manufacturing capacity that exists. And India is a good example, but there's others that can definitely do it. And the World Health Organization from the beginning has had the technology access pool system to make sure that these technologies are shared from pharmaceuticals. And now the mRNA hub in South Africa is the way that we would like to go forward. And if Moderna were to share their technology, it would accelerate the process enormously and would allow us to be prepared for variants and any new pandemics that may come.
Yeah, this is a huge debate, and when we talk about what lessons should be learned, this has got to be one of them. A few cautions, though. mRNA vaccines have been fantastic. and it was here that those first conversations happened 2.5 years ago. Just should remember that we've only had 2 mRNA vaccines so far, one from Moderna and one from Pfizer. We don't yet know what the role of mRNA vaccines are in normal other vaccination. That's the honest truth. And so I would caution against the countries, the world, now rushing to think mRNA vaccines are the answer to everything. I don't think we know that yet, and we don't know what the mRNA vaccines are going to do for EPI programs, childhood vaccinations, or for other vaccines going down. So I would keep a plural approach, first thing. Second thing is it's not just rich countries where the vaccine manufacturing is, it's large population countries where the vaccine manufacturing is. If we leave it in those countries, and India deserves enormous credit for its manufacturing, but if we leave it in countries with hundreds of millions of people and you have another pandemic, they will have to look after their own citizens first. So you've heard it at Davos first. I would set up a global network of small population countries, Singapore, Costa Rica, Rwanda, Senegal. You could have it in competition, funded centrally, intellectual property protection, manufacturing quality, expertise, regulatory alignment, everything you need in order to be producing vaccines we need today and tomorrow, but be there to manufacture for their own populations and be exporting within a week or two. I think if we don't set something like that up and we leave it in US, China, India, etc., then we will have the same problems of nationalism in a decade from now when we have another pandemic.
Let me just ask Amitav on this point about sort of diversifying manufacturing, but you have 1 billion people to worry about in India itself, and like a lot of big countries, Jeremy was saying, that is the sort of priority. To what degree do you think countries like India can provide Gavi, for example, with the vaccines they want to send elsewhere, or is this a different scale of a pandemic that we really can't rely on a country like India the way they may have in the past?
We had 2 vaccine manufacturers in India when the second wave of the COVID hit India, and it was a very devastating wave. We are a country of 1.3 billion people. 1.3 billion means more than 26 countries of Europe, plus another about 1 million people more. And it was very important to take care of the domestic population. Today, we have 10 vaccine manufacturers in India. We've ensured that every single Indian gets double shot of vaccines. Today, every Indian is going through his 3rd phase. We were the first country in the world to export vaccines around in our neighborhood and to other developed countries of the world. We've done it now after we finished our population. We are back to exporting our vaccines. We are determined to be the vaccine capital of the world. 14 other vaccines are in their clinical phases. We believe that nobody is safe till everybody is not safe. And we are convinced that Indians will manufacture vaccines for the rest of the world. And we do not believe that anybody can be safe till we do not provide vaccines to Africa and all other emerging markets of the world. Economic growth will suffer, education will suffer, health outcomes will suffer. All development will suffer if we are not able to provide vaccines, and it's incumbent. The vaccine manufacturers have done great innovation. They've brought in great technology. They've demonstrated top-class entrepreneurship. But now is the time to reach out and do away with their intellectual property rights and provide vaccine manufacturing to the rest of the world. The world requires this.
What is more important going forward? Is it therapeutics or vaccines? Let's start with you. If you want to sort of level out the different outcomes we're seeing across the world.
Diagnostics. You've got to, if you don't know something's there, you can't do anything. So you need to be able to test. So you need diagnostics, and never leave diagnostics out. And of course, there's very few infectious diseases where vaccines are the answer to everything. There are some, but you almost inevitably need therapeutics and vaccines. And vaccines have quite rightly had the most attention, but we're going to need therapeutics for this and other viral infections in the future. So therapeutics needs more attention than it's had, and of course vaccines. And then finally, infection control and personal protective equipment and oxygen. Oxygen has probably saved as many lives as almost anything else in the last 2 years, certainly before vaccines came along. And yet, trying to cobble together a coalition to get oxygen around the world over the last 2 years has been a nightmare, an absolute nightmare. Something as simple as oxygen.
What more can be done, speaking of sort of therapeutics and maybe some of the other things you mentioned, to accelerate the, to make sure that, poorer countries are getting Paxlovid, for example? What efforts are underway, do you think, are working, and What are people not thinking of yet?
So that they get over.
So to get the sort of getting Paxlovid sort of out to sort of the leading therapeutic to lower income countries.
So I think it's connected with what I was saying before. So there's been this approach to doing things. So it's not only vaccines that have the IP, also therapeutics, and everything has to be looked at as an ensemble. It's a holistic approach to it, and it has to be done at speed. So distributed manufacturing is fundamental. And I'm from Latin America. There, we're 8% of the global population, but represent 28% of COVID deaths. And that's what it means in the end. Every delay or any solution that is not, the epidemiologically sound solution is to go fast and cover as much territory. It's also the right economic solution, but we're not taking, and it's also obviously humane, but somehow the emphasis has been more on a profit model rather than a model of putting people first. And think, we can all challenge ourselves to say, can we measure our success in terms of lives saved rather than profits made?
Can I just make a comment on the Paxlovid? Because it's really, sorry to have a second go at this, but therapeutics is really important. But you've got to have a health system that can deliver therapeutics in a time window that you need. Truth is, outside Japan in influenza, no other country has got that in place. Because you need easy and no barrier access to a test, and then you need easy and no barrier access to the treatment. And if those aren't together, you won't use the drug in the short window that you have. So if we're going to think about rolling out acute viral therapies, we've got to think of the health system that can deliver that. And at the moment, the only system I know in the world that's succeeded with that in influenza has been Japan, who's used historically about 80% of all anti-influenza therapies. So let's not just think we're going to get Paxlovid out around the world without thinking of the health system that can deliver it.
And the system is the same thing for vaccines, because vaccines are the most widely distributed health intervention. About 90 to 91% of families have access to at least one dose of routine vaccine, so the best. But that's around young families, children. We don't have immunization programs in developing countries for the elderly, even, frankly, for healthcare workers and for people who are immunosuppressed. So we've patched on to existing systems. Some places that's worked really well. They've gotten to very high coverage very quickly. Others have not. And it's one of the challenges as we think now about, in peacetime, what systems do we want to build? It's making sure those systems are in place. And we have to think about it. If we take a longer-term view, with demographic transitions, we're going to have older and older populations, and we're going to see the advantages of bringing to them vaccines that can prevent diseases in those populations that are cost-effective, but then, of course, are also available if there is a pandemic. So this is part of what has to happen as we think about preparedness moving forward.
And who's the lead there? Is it national governments? Is it WHO?
It's always national governments. Now, at the end of the day, obviously there are populations that aren't being served, and so sometimes you have to go into people who are stateless or in conflict, but it has to be the government systems working with civil society for access and being able to do that, because what you need is a sustainable system. It's not about just delivering something quickly. You have to build it out, and you have to have it available for everybody in the countries, and it's getting to that norm that is so important. It took us 24 years to go from, probably 59% coverage, up to the coverage that we have today. It's a slow process of building out those systems. If we could accelerate it, we absolutely should for the SDGs going forward.
Can I add briefly that the big pressure now on many countries is the debt burden. So many of the countries that don't have adequate or very inadequate health systems are crippled by debt, and they're spending more on debt servicing than on improving their health system. So that's an immediate problem, again, of the bigger solution. But I think also in the terms of addressing the current situation, the mRNA hub in South Africa, set up by the World Health Organization, is something that allows a solution now and for variants, so that we can continue to sustainably respond. And we're talking here about sustainable responses to the pandemic. So it's an ask that Dr. Tedros had made to Moderna and to Stefan Bancel himself, whether this technology can be transferred so that production can be done at scale.
Yeah, and we don't think this is the priority right now. As Seth knows, we are now throwing those into the garbage. It's sad to say. I'm in the process of throwing 30 million doses into the garbage because nobody wants them. We have a big demand problem. We right now have governments. We try to contact, not only Seth, who is doing great work with his team trying to get demand into the countries, but also we contacted through the the embassies in Washington, every country, and nobody wants to take them. And so the challenge we have now is a very different situation than we had 2 years ago. The problem we had 2 years ago is there was no mRNA capacity in the world, zero. The situation is very different today. Moderna has 3 billion doses of annual capacity. Pfizer has 4 billion doses, that's 7 billion doses, and the Chinese don't want the vaccines of mRNA. So if you just take the Chinese population out, you have more than a dose per person, and as we just discussed, the issue in many countries is people don't want vaccines. In the US, people don't want vaccines. Around the world, we have a lot of people who don't want the vaccine. That's a problem Seth and his team are working against. So we don't have a capacity issue around the planet. It is not true. It was true 2 years ago. It's not true today.
Seth?
Yeah, just to put into perspective the numbers on that. So the overall coverage in the world now is around 59 to 60% with at least 2 doses. In lower and lower middle income countries, it's now up to 46%. So there's still a disparity there. But obviously, averages don't take into account the differences. There are actually 34 countries at the beginning of the year that had a coverage rate of less than 10%. That's now down to 18 countries. 14 of those 18 countries are fragile countries, and they need a lot of help to be able to roll it out. Now, can it be done? Absolutely. We've rolled out vaccines in the most difficult places in the world to all age groups. The challenge is they turn on their telly and they see the rest of the world saying this isn't a problem anymore, and they got a lot of problems. It isn't getting that local demand, and that's what we need help right now from all of civil society, media, international institutions, is to basically make sure that countries understand that it may not seem like a priority now, but if the next wave comes out and you haven't protected your high-risk populations, you are at real risk. What happened in India, what's happened in other countries, this is something that we have to make sure people are aware of.
If lower income countries are on average a lot younger than higher income countries, is that make vaccination less urgent in your view? That actually that 46% number is not that bad since the average age is 25.
Well, I mean, what we're interested in is what is the coverage in healthcare workers. That's about 75%, and in the elderly, 63%. Those should be well above 90%. And of course, if I use the numbers in Africa, those are lower than those averages. So yes, it has to be those high-risk populations, but it's not ours to set the goal for countries. Countries need to set their own goals based upon, their priorities. But I mean, any country that says we're not going to vaccinate our elderly or our healthcare workers, I would say has a problem. And what Stefan has said, this has become highly politicized, and we now have wealthy countries that aren't using vaccines and are missing vaccination in their populations. And of course, same social media system. This spreads across the world, which makes it a challenge.
So this issue of vaccine hesitancy and people not taking vaccines has been heard in many countries. In France, we heard at the beginning, and you need public information campaigns and reliability and availability of vaccines. So there hasn't always been there for all the issues raised here. So that's the uphill struggle that is there, but it's not necessarily that they wouldn't be taken if the right communication and availability was there. So unfortunately, lots of doses have been lost, which is tragic given that so many people are still dying from the virus. So we really need to address that and create a sustainable source which is reliable and people can definitely trust it.
Aumentar.
So one of the big lessons of the COVID pandemic is that vast segments of your population go below the poverty line because they lose their jobs. Businesses come to a standstill. People are not able to go to schools. And therefore, 2 key lessons from the India story. One is that you should be, the world must use technology to leapfrog, to be able to digitally transfer resources to people who do not have resources. We were able to transfer resources to about 840 million people so that they do not get into poverty line. Second big lesson of the COVID pandemic has been, to my mind, that a lot of people go below poverty line because of lack of tertiary care, because everybody is focusing on COVID vaccines. Every other disease is not taken care of. And therefore, people are going below poverty line because of a whole range of other diseases. And therefore, a very strong health insurance scheme. We today have in India a health insurance scheme which covers 500 million Indians, which is totally paperless, cashless. That's more than the population of USA and Mexico put together. You can be in any part of India, move to another part of India, you will carry your health insurance. And thirdly,
Can you get that to the US, please? Could you get that to the US, please? I think
Yeah.
if we could.
Well, US is
Paperless, that would be a
US is. I was in US recently, and I discovered that my daughter who works in San Francisco, it's all paperwork. Whereas in India, the CoWIN app, every single person has got vaccinated digitally through the CoWIN app. It's totally a paperless, cashless exercise in India. It's totally digital. Whereas all across the world, it's been paper, and that's why it's been very smooth. We've been able to cover 1.3 billion people of India totally through a digital app.
last on this point.
Yeah, I think the impact on education and economics has been massive. It's, for what in my regard, the four circles: the direct health consequences, the indirect health consequences, the economics, and then the geopolitical influence. But the answer to that is not to blame the pandemic in a sense, it's to prevent them bloody happening in the first place. Because if you have these global pandemics, it will affect all of those four circles. And you'll maybe be, I hope, better prepared next time. The response will be better, the political systems will be better, but don't think you'll get away without some disruption. So the most important thing to realize in the 21st century, with ecological change, climate change, urbanization, travel, we are going to face more frequent and more complex epidemics. So let's prepare for them properly, let's learn the right lessons, and let's put in place the things that we require in 2022, but let's have some vision of what we need to get to by 2030. Because we will be here again, and we cannot ignore this one or the previous 20 years of experiences.
But you say that this pandemic is not yet over, and we should be thinking about the next one, and you're seeing governments lose interest in this pandemic, cutting funding, and as you mentioned at the very start, there's a kind of growing sense of complacency about it. How do you sort of unwind those paradoxes?
Well, I'm not a politician and have no intention of becoming one. But we've got to be able to, if it translates, be able to chew gum and walk at the same time. We've got to have political systems that allow us to deal with today's and tomorrow's real issues, whilst putting in place plans for the longer term. And one of my worries is with political cycles, in all types of government, is the focus is only on the today, on tomorrow, on the next electoral cycle. And have we got the capacity to address the longer term issues?
Stefan?
Yeah, and I think also industry has also to lead and to help. I mean, as Seth and Jeremy know, there's around 15 viruses that WHO and everybody has been saying for years, those are the source of the next pandemic. But very few pharmaceutical companies have worked on those vaccines, very few, if any. So one thing that we decided and announced in March at the CEPI conference is that Moderna is committing to develop the vaccine for the 15 of the top priority list of the WHO. We'll do it either in partnership, because we don't want to reinvent the wheel. If there's an excellent center somewhere in India, in the UK, in anywhere, for example, we're working on multiple resistance TB new vaccine with Institut Pasteur in Paris, or with a new rabies vaccine with Institut Pasteur in Tunis, because we want to use the best talent. But what we said is we will take those, we'll do the preclinical work in animal, we'll take those to the clinic, because I believe if we had done those things for a coronavirus before SARS-CoV-2 became a thing, we could, I think, have saved 4 months to launch. 4 months would be a dramatic difference. September versus December will have saved so many lives. So that's on the clinic side. And then because of what I said on the capacity side is there is now enough capacity in the world between protein technology and mRNA technology to have much more capacity. So if you think about a 6-month launch versus an 11-month launch, you could have, with the 7 billion doses of Pfizer and Moderna, you could have 3.5 billion doses ready to ship the day of approval. That would be very different. When the vaccine was approved in December 2020, we could only ship 20 million doses. That's all we had, because there was no capacity.
So one important point is that I want to bring it back to the WEF conversation, because I remember after the Ebola outbreak in West Africa in 2015, at the top of the risk registry coming out of WEF was pandemics. The next year it was gone. And it's this cycle of panic, neglect, that is really the problem. And you would hope now that people now believe that a pandemic, we've just passed 500 million cases, where at a time, luckily the death rate isn't the same as in the Spanish flu, but because of vaccines, but it's certainly 15 million deaths is big enough. What we need then is that reminder for government, because I agree with Jeremy, coming from the business side as well, because this, in peacetime, is the time to prepare and do that. But in peacetime, if you've ignored it and wiped it off your list of priorities, then you're not prepared when it happens again. We've learned in other sectors not to do that. Firefighting, in warfare, where you, in peacetime, use to plan. We need to be doing that for diseases as well. And we did a disease planning exercise here in Davos, I remember. And with all the sectors, with hotels, with transport, with food suppliers, education, and did we learn the lessons? And the question is now, will we? That's I think really important.
So as you mentioned, there are no politicians on this panel, which frees everyone here to speak their mind. And what I want to ask each of you is, you're writing the report card for your government, looking over the last 2 years. Can you give us a grade? Can you give us, where they start their semester, where they finish? Start with Boris Johnson. What does Boris get? He was a indifferent student, but.
You studying with me or down at Stefan?
I'll start with you, since.
Read the book. So I would.
Give us a one-paragraph synopsis.
D+ or C-.
Okay.
I mean, A, because.
Is that a third or a second? I don't know.
A because. The response at the start was too slow and we did not take it seriously as a government. But secondly, and in my view, even more importantly, did not learn the lessons through 2020 and therefore repeated the mistakes of the first quarter again. And for a child in education, that's just awful. You've got to learn lessons. So C- or B+. Okay. D+.
Barely passing. You're a citizen of the world, so I'll let you sort of choose your country, or Latin America, Africa.
I would just say, in general, I think governments didn't learn the lessons, and some lessons have been learned, as was said by the panel, but the lessons of the HIV pandemic were not learned. So it took 10 years, 12 million people died in Africa before generic antiretrovirals were available. So that was an IP barrier for so many years. Mm. And then, to again have the same system again now means, and there could have been conditions put at the beginning because there was collaboration and many of these, in fact, the great investments by governments in vaccine acceleration. So that, I think, and that can be remedied by agreeing at the World Trade Organization that an IP waiver is absolutely necessary now and for the future for any pandemic.
Are you a more generous grader? I would say full disclosure, you do work for a government-backed organization.
So, for the reason of making India the vaccine capital of the world, for having provided vaccine to 1.3 billion people of India, and for ensuring that you are able to do direct benefit transfer to people who'd gone below poverty line, and not making yourself dependent on the wealthier countries and on Pfizer and Moderna's of the world, I would give Government of India A.
Seth, you want to deal with the Americans? I guess there's two.
I don't know. I live in Switzerland.
Two students there. So
I just want to make a comment on India because I think it's important. I agree, India has done a very good job, but India also, we did the tech transfer to India of those two vaccines for the purpose of supplying India and the rest of the world, and only one of those two got supplied during that period. It started out with both, and that really left some countries in a difficult situation.
But that happened because India was the first large country in the world which was hit by a devastating second wave. Mm-hmm.
Yeah, but just to make that point. So it's interesting, if I want to make myself an American, when we were sitting here at discussing creating COVAX, there was an American president down the hall who was saying, there's nothing to worry about, this is not an issue, we don't have to do anything about it. I think the US had the best scores in pandemic preparedness of any country in the world, but it didn't live up to those scores, certainly early on. And I think it's tragic that the US has just passed 1 million deaths and a third of the population is not vaccinated and 2/3 not boosted. I mean, I can't give good grades for that, although I have to say that the Biden administration has stepped up and tried to provide leadership, but it's very challenging and politicized right now. And I think this is something we have to not have in pandemics, is politicization, because I don't see how you work as a global community in those circumstances.
Stefan, do I make you French for the purposes of this exercise? Or,
So if you make me French, I will give an A for Mr. Macron for the courage to putting the pass at the end of the summer last year, which I thought was fantastic, and you saw the vaccine uptake went up like crazy. I think the US government did an amazing job with Operation Warp Speed and Monsef and the team to fund 6 companies to do 6 vaccines that we basically use for the planet. Everybody forget Moderna didn't have the money to run the clinical study back in 2020. We didn't have the money, period. And they funded the studies. We gave it to everybody, the data, to Europe, to WHO, and this has given the Moderna vaccine at least to the planet. The piece that I give every government an F is we got 0 help for manufacturing, 0, and we wasted a lot of time because nobody was helping us. We got help for clinical trials, but not for manufacturing. And Canada was fantastic. When we started to do our first agreements, we asked for 20% down payment to help us buy raw materials. And when the Canada team learned that, they gave us 100% of the money forward so that we could buy more raw material for other countries.
Wow. But they were a little bit delayed in rolling out the vaccine in the end, Canada, weren't they?
Because they had a little problem with their neighbor south. We didn't let us export.
Oh, I see. Okay.
And Canada also was wonderful because they supported dose donations at a time when we didn't have doses. They helped set that up and pay for it for the world.
There's more love for Canada?
No, one of the key lessons of what's been said, though, is something done early is a lot better than something done at bigger scale late.
Yes.
If you'd financed stuff early in May of 2020 and said, we're going to do this at risk, as Warp Speed did to some degree, you'll be much better off in the long term. Otherwise, you'll pay more later and you'll have a lesser effect. So you have choices to make. And I think if we rewrite history now and we sort of gloss over this and say, well, actually, everyone got a B+ or an A-, then we won't learn any of the lessons.
Yeah, I mean, my biggest frustration in the February, March, April timeframe of 2020, I asked every foundation in the world, please give us some money to build manufacturing lines. Didn't get a cent. I asked every government in the world, didn't get a cent. What is crazy about the story of this world, you know how we get some money to build manufacturing? We issue shares on May 18 on the stock market, $1.3 billion of shares we issued to buy raw materials and machines because nobody else was helping us.
Great. So we're going to have, I do want to also bring in this wonderful audience, and we're going to have a sort of microphone going around. But there is one other important topic that I wanted to, so please think of your questions, and we'll get to them shortly. There is one other topic I wanted to talk about, which is in the spirit of sort of equity and the pandemic, is I'm trying to understand the impact on development, on poverty, and I think I read somewhere, maybe Gabriela, she read it, something that you've said is that every 30 hours there is a 1 billionaire who is minted in the world, and there are 1 million people who fall below the poverty line. Extreme poverty, and I think maybe in 2020 alone we added 125 million people to the ranks of the extreme poor. And maybe how far has COVID set back our efforts, our sort of fight against poverty? And what would you say is the key thing that can be done about it in the short term and maybe in the longer term?
Yes, thanks
Start
for
with
the
you, yeah.
question. Yes, so the rise in billionaires has been unprecedented during the pandemic, and there's been several sectors where that has been mostly concentrated, and one is in fact the pharma sector, because COVID has been one of the most profitable products ever. So that's one point to discuss, and our report out today is called Profiting from Pain, how those delays in making this technology available and really having people vaccinated early has contributed to that. but has also, as was said earlier, it's not only the direct health impacts, but it's the economic, social impacts on all parts of the population, and in reality, an increase in inequality, reversing the trend of the last few years where inequality had reduced between rich countries and poor countries. Unfortunately, now it has widened. And the statistic we're saying is every 30 hours, a new billionaire was minted during the pandemic. And in the same rate, in 2022, 1 million people are falling into extreme poverty. So that continues now with the food crisis, the inflation crisis, the war in Ukraine. So we have a really critical moment and a moment to make different decisions, a turning point, as the World Economic Forum has wanted to call this session. So we need to really find different solutions, not the same ones of the past, for these really critical times.
Jeremy, you're curious sort of how you, since you lead the world's second biggest charitable organization, how are you thinking about, what can you do to help on this front?
So yeah, I mean, we're not like Gabriella, we're not an aid agency. We're a science-based organization. So that's where I think our contribution comes. I mean, it's the first time it's been mentioned, inflation. I mean, inflation and what's happening in the horrific war in Ukraine is going to add to the turmoil of our time, whether increasing debt, economies falling over. You've seen what's happened in Sri Lanka and beyond. We're going through a period of incredible challenges at the moment. And that's the time when I think politicians, but all the rest of us, have to step up. It's purpose of WEF in many, many, many ways. I mean, from our perspective, we've made a decision for the first time in our history, actually, that we will commit to a baseline of future funding, even if that means our asset base gets less. We've never made that decision before. So that means we're commit to, in the bigger picture, it's a tiny amount, but it's 16 billion pounds, so whatever that is in other currencies over the course of the next decade. That's the first time we've ever done that, because we think over the next decade, there are just going to be so many problems that we have to address, from climate change to infection, mental health, and science itself, that now is the time to invest, because you'll gain the benefits years to come.
Great. Let me open up to the floor, and please introduce yourself, put the question in the form of a question, and if you want to identify someone on the panel, please do so that you are hoping to address it. Let me start here in the front row, and there's a microphone coming right there.
I think it's a very timely conversation that we have, and one of the way of looking at the impact of the pandemic.
Who you are, sorry.
I am Dr. Kezavino Aram from India, and I head the Center for Child and Public Health, is the impact on the world's children. We have 44% of India made up of children, and the world over. I think what this pandemic must give to us as a lesson also is preventive health services and the disruption. Mr. Khan spoke about the cognitive loss, but I think the loss in preventive health services reaching children has been quite severe. So my question to this panel, and each of you can look at it in different ways, would be how do we prioritize children as an agenda item to recovery of the planet from the pandemic, but also in the way that we address poverty, future looking.
Gabrielle,
and within children, girls in particular, so 20 million girls are likely not to come back to education as a result of having lost this vital time. So lockdowns had a big impact, and there's been also enormous domestic violence, gender-based violence. And so I think we need to rethink how these epidemiological measures are taken in the future to consider the impact on children and girls and other vulnerable populations.
Seth?
So, in terms of the area we work on, it's mostly focused on children around the world. And we saw a reduction, interestingly, not in dropout between different amounts and doses of vaccine, but rather the number of children and families who ended up zero dose. In other words, went from being in the system to out of the system. And that's so we're now operating at a much higher baseline that we have to move towards, because the goal by 2030 is to try to, erase that as much as possible. India took a particularly hard hit, as did Myanmar, the two examples that were more. But overall immunization is down around 4%, which may not sound like a lot, but we've been chipping away at it, getting it up, and our hope is to bounce back and then to continue on our way up. But if not, we're going to see other outbreaks of disease that are going to overwhelm the health system. And so that's why, from a priority from the beginning, was to restore the systems, get the vaccines out, and make sure people are included.
I think it's a very important point which the doc has made there. And from an equity viewpoint, there are 4 important issues to my mind. One is, how do you provide security net for people who are getting below poverty line during that period of a pandemic? One way out is a direct benefit transfer, and this would require a huge amount of digitization effort. In India, fortunately, we had the biometric, and we had bank accounts, and we had mobile. Every Indian has a mobile, every Indian has a bank account, every Indian has a biometric. We could do that direct benefit transfer. The second is, if you do not have that, then governments across the world will have to think of universal basic incomes. And thirdly, I think primary health has to be the focus in the coming years. Very, very important that we lay a lot of stress on primary health and wellness centers across the world. And fourthly, for those who've lost 2 years of learning, there will have to be a huge, massive, concentrated focus through technology, through concentrated lessons, etc., to make up for that loss in the last 2 years.
Catch up.
Right, someone else right there in the front, second row, right here.
Thank you so much. My name is Kwame Bachwe. I am a global shaper. Thanks for this very critical conversation. So a couple of the panelists mentioned vaccine hesitancy, which has created demand problems that Mr. Bansal referenced. I know for a fact that this vaccine hesitancy that we have stems from a deeper problem, which is a distrust that people have in institutions. We know that this is not our first pandemic, neither would it be the last. For the sake of the future, what are your institutions doing to rebuild the trust of the community? So in future pandemics that we have, when we issue vaccines, people would be more willing to take them.
Do you want to,
You don't build trust in a pandemic. Trust is built over years and years and years. And again, a comment to our political friends, don't undermine those critical institutions. Because if you undermine them with your comments, and certain countries have done this, those institutions will not be there and will not be trusted by their communities when you need them. So that's the most important point. And secondly, Wellcome did the Global Monitor, I think it was 3 or 4 years ago now, asking in 150 countries, and it's really interesting, the results of that in terms of trust of public health and trust in vaccines was incredibly predictive of those countries that would then have high uptake and low hesitancy. So it's Rwanda, I'll pick out as an example. If you have high trust in your institutions and your vaccine schedules before a pandemic, you'll probably have much better trust in it during the pandemic. So don't try and wait until a pandemic comes to try and build trust. Build it all the time. And don't undermine it.
There's a question right there, maybe this gentleman in the blue shirt.
Okay, my name is Tom Plummer. I'm one founder of, I'm a technology pioneer of a drone company, a drone delivery company. And we were lucky to sign an agreement that we want to bring 12,000 drones over the next 5 years to the Sub-Sahara with partners in Africa. And we would love to, for sure, help distributing on the last mile. Now the question is, you mentioned hesitancy on taking the vaccine, but how do you feel the last meters, the last mile to the, especially rural communities, have been a problem to distribute? And because we are working in Malawi and we faced that things got thrown away because they were expired, and now we are delivering some vaccines, but still at a small scale. Could this help, latest in the next pandemic or even in this one? And how much is the last mile problem a challenge in your view?
Seth, you want to?
So obviously, any technology that improves delivery on time is an important technology. And we've discussed at this forum many times drone delivery of blood, in African countries, which is a way to protect the blood bank. We've also discussed delivering of vaccines or special, vaccines that have a use case like a rabies vaccine where you don't know where people will be bitten and therefore you can get it there, or snake bite, anti-snake bite serum, to allow you to deal with that. So I think those are very powerful. The challenge is how do we make this cost effective and usable in a broad set of places? And that's now being tested in many places, and I think it's really exciting. They love it. In Ghana, there was a system that got put in place. The opposition was picking on the government at the time. They were like, this is obviously you wasting money. And when COVID hit, they were the first to cheer on the fact that it was being used to deliver products. So I think this is coming technology. We're just going to have to optimize it and use it as best as possible.
Question back here on right there.
Thank you. I'm Ernest Darko, co-founder of the Broadreach Group. I wanted, actually, maybe it's a bit of a caution. I've heard hesitancy be thrown out there as this is the reason why people are not coming. And I'd seriously like to challenge that. I think we can only assess the true impact of hesitancy when you've provided good access, right? Only in the context of there being really comprehensive access can you then actually say, now who's not coming forward? And in our experience, we have found that when you provide access, meaning take the vaccine to the people, talk to them in their local language, deliver it to them, we've seen very, very little actual true hesitancy. And we're succeeding in vaccinating up to 90% of the target group we set out to vaccinate. But so often, I think we're missing the whole point that trying to vaccinate almost an entire adult population is unprecedented, right? We've never just done this as a human race, right? And if we go back, I've been doing public health for 20 years. We've not delivered much of anything that exists, even when it's donated for free. We've not been able to deliver it. The diflucan, the ivermectin for river blindness. We have all these public health examples of where it's available for free and the systems are just too weak to be able to get this to where it needs to go. So I guess if there is a question here is, I have not yet seen any donors who are willing to fund primary care strengthening or health system strengthening. Do you think there'll finally be a willingness now to look at fixing some of these fundamental drivers of health systems as opposed to this vertical focus on individual diseases only? Because already we're seeing COVID become its own vertical again, and it doesn't then benefit us for what's going to come in the future where you need a strong health system. Thank you.
Jeremy, is that a fair critique?
Yep. I think there is a little bit more hesitancy than you're suggesting in your question, but I absolutely accept with the tenet of what you're saying. Yeah, absolutely. And more horizontal systems that aren't vertical structures. And I would really caution against us taking a lesson that it's another vertical structure we need. I've argued, although my own background is in emerging infections, argued strongly against setting up a new silo for emerging infections. I would absolutely try and build that into horizontal systems that can deliver broad healthcare.
Question back here toward the end.
My name is George Vredenberg. I'm chair of the Davos Alzheimer's Collaborative, which is follow-on to Gavi and CEPI to try and deal with the Alzheimer's pandemic. But I'd be curious as to what lessons we've learned in the infectious disease areas that we might think about in terms of chronic diseases, particularly of aging as the world's societies age.
Anyone?
I feel I've taken too many questions. There's always lessons to be learned. I think there's some lessons to be learned on my world of infectious diseases from how non-communicable diseases have been dealt with around the world as well. So I think there are lessons. It would be good to have a conversation coming out of this, this conference on that, especially having been involved in setting up, as Seth was with Gavi, and then we were very involved in setting up CEPI, and the lessons to be learned from that, and how best to use, and not use, work with WEF as a forum that can bring together those discussions. Be very happy to pick up that conversation with you.
I want to push with Stefan on this one. Is there anything, that there was, obviously, the world's interest was focused on this, the governments were focused on this, resources were focused on this, and I guess similar things are not happening with other diseases, and I wonder if there's any way to change that, or if even that's the right diagnosis of why we haven't, moved as fast in other spaces.
I think the difference is how complex is the biology. I mean, the thing where, and Jeremy, tell me if you don't agree, I think we got lucky with this pandemic is this was a simple virus. I like to remind people that HIV was discovered 40 years ago. We still don't have a vaccine against HIV. And the other place where I think we got lucky is this was not in the first wave touching the children. The flu in 1918 was killing as many children as older people. Just imagine how awful it would have been the last 2 years if we had lost as many children as we lost elderlies. So on all the central nervous system disease, the big issue is there's so much about the biology, how the brain works, that we still don't understand. So I think investing a lot in early academic research is most probably our best chance as a society to get this done, because I don't think anybody in the industry has really the scale to do that type of work. I think it's really kind of NIH academic type of work to really understand mechanisms of disease. Because once mechanisms are well understood, I think industry has a good track record of being able to make a drug out of it, or a vaccine, or a treatment. But the challenge, and we saw it with a recent Biogen, drug, is this is such a complex disease, and we have to all be very humble that we still barely understand how it works, how it happens, how it evolves over age.
Disease or diseases.
Yes, yes. Thank you.
There's a question right here in front.
Hi, my name is Alex Von Plato, and I lead the healthcare practice for Publicis Group. We're a marketing and communications firm globally. I want to ask you, what do you think of the source of the anti-vaxxer movement was? And, I want to compare it to the leveraging of the community. I've been working in HIV for over a decade too, and I really see that gay men were the force behind creating the therapeutic success for HIV and making it a chronic disease that people die from many other things before they die from HIV. I think also in Africa, there were stories that Ebola leveraged, the therapies for Ebola leveraged the religious leaders in community to build connections of trust, to let people, accept the health from whatever limited healthcare system there was. Again, I'll repeat my question. What do you think the mechanics of anti-vaxxers was? And what can we learn from that to create a pro-vaxxer groundswell?
Seth.
Yeah, so let me just start, because I agreed with what Ernest said, but I want to make a point. In this pandemic, we've seen much more anti-vaccine activity than in others. Of course, the highest confidence in vaccines is in Rwanda, as Jeremy mentioned. The lowest is in France, Louis Pasteur's country, even though they still vaccinate. So it used to be that the anti-vax movement was mostly in wealthy countries. Why? They don't see the diseases anymore. There was an ability to be complacent about vaccines and the need for it, combined with organic movements and everything else. Different this time. It became very politicized. And with that politicization, we also saw nefarious groups using this as a way to leverage, creating distrust in governments, distrust in institutions. And that then has now moved out in the social space. And so in the developing world, the problem is not an indigenous anti-vax movement there. It's there having concerns because they're hearing of what's happening in the rest of the world. And that's where local leadership is so critical that Ernest has talked about, getting local leaders to speak, to understand, and to get people to be confident. But I think, I don't know how to solve the problem when politicians, well-educated politicians with science degrees, are, pushing out things that don't make any scientific sense. That is a problem, and it certainly affects people's confidence in institutions and interventions.
Well, I'll take more questions and to continue this fascinating conversation, but I've been several times now been told that time is up. On behalf of Politico, I want to thank the World Economic Forum for making this possible, and above all, I want to thank this wonderful group of panelists. Thank you so much.
Thank you.